scene is set. So, first of all, if I can introduce Gus Gazzard, consultant colleague, and he's going to tell us his viewpoint of why MIGS should definitely be a part of glaucoma management in the future. Gus.
Thanks very much, Sal. I think we've already heard very nicely this morning some of the enthusiasm, particularly for one specific device, although I think I'd probably call the Zen a moderately invasive glaucoma surgery because of its involvement with the conjunctiva. And we've heard some of the enthusiasm for the other minimally invasive glaucoma surgical devices and the plethora of options that we now have open to us. And I think Kwang's very nicely set the scene for a discussion around what patients care about and what it is that they are most interested in the management and the care of their glaucoma. Now, I'm not going to dwell on or discuss what devices we're talking about. Keith's done that very nicely for us. Why? Well, we know that we're talking about reduction of intraocular pressure for the preservation of a retinal ganglion cell life, therefore for the preservation of visual field, therefore for the preservation of vision-related quality of life. There are a lot of steps in those surrogate markers, but ultimately the risk of using IOP as a surrogate marker for quality of life has been well described, I think, by Kwang and others previously in this meeting this weekend. I'm going to think a little bit about for whom instead of what, with what at the same time as what, and what that does for our assessment of risk, and then briefly mention at what cost. So we're talking about minimally invasive glaucoma surgical devices for the future. What is it that we are able to potentially offer our patients, and why might we consider to do those? There's a whole plethora of choices. There are different devices, different techniques, different tubes. I'm not going to restrict myself to just things that we stick into the eye. I think we also need to be just considering potentially endoscopic cyclodiode. I'm not a big fan of destructive procedures like that because of the impact that they have on aqueous production in the long term. But a lot of people are presenting and reporting very good results from that. There's a whole range of devices in the offing that are about to come online and be available, and there's a lot of people in the audience already using many of these. Clearly, we're all, to some extent, believers that they are worth the risk that we're inflicting on patients. But why? I don't think they all sit in the same place in the treatment hierarchy. I think we have to be exquisitely careful that we don't dismiss some of these devices because we're talking about we're having different discussions at the same time and we're failing to communicate. I think the patient for whom a Zen may well be a very valid answer is going to be a different patient for whom a discussion around whether or not it is worth using an eye stent or potentially a hydrus, or potentially a trabectome, or potentially an ab interno canaloplasty, or any of the other minimally invasive options which are being touted out there. I think they may well be a subtly different patient group because what we are all discussing, and as we all know from every decision we make, is a risk-benefit analysis and a risk-benefit assessment for the patient. And my thesis for this talk, and also for how I practice, is that the risk-benefit analysis we're making for our patients is sometimes wrong because we underestimate the benefits that some of these devices confer upon our patients. And Kwang very nicely touched upon and elucidated some of that actually we underestimate the burden that some of our alternative methods of reducing intraocular pressure places upon the individual patient. So it's all about the risk and the benefit. It's a balance between those two. And then we have to consider the cost if we're going to consider healthcare systems as a whole. So a procedure of only modest benefit may well be worth the cost if there is only a minimal additional risk. That much is straightforward, but sometimes I think that gets lost in our discussions. That's ultimately some of the argument for using selective laser trabeculoplasty as a treatment at all, particularly as a primary treatment. It doesn't last forever. in some patients, doesn't even last for that long, but it seems to be, when done appropriately, extremely safe. MIGS seem to me to be a step up from that they're an additional small risk for an additional benefit. I think moderately invasive glaucoma techniques, like the Zen, which does involve conjunctiva, are then a step up from that further. And there's still a place for the very labour-intensive, less predictable and potentially risky procedures of trabeculectomy and large tube surgery. There's still a place for those, clearly, in some individuals, because the benefits are going to be greater and thereby justify the level of risk. We also have to remember that modest reductions may be all that many of our patients require. We have to be cautious and be careful about over-treating patients, which I think traditionally has been done, particularly in the last decade, a great deal with medications, partly because of the influence of big pharma on asking us to chase the pressure. And Velota yesterday talked about chasing the pressure and not adequately balancing the whole picture for the patient in a surgical setting. I think the same thing has happened medically. Many of our elderly patients are heavily over-treated with medications to a degree that they probably don't need, and it may well be that part of that is our fault because we've chased a target pressure too much and failed to adjust that appropriately for the age and severity of the disease that we've got. And I think we may need to reassess some of those targets in the context of MIGS. And then a greater level of benefit may be worth a greater risk, and I've said that. Now, what's wrong with medical treatment? We know all of this, that if you do remember to take them and they don't actually kill you, atrophy your orbital fat, permanently wreck your ocular surface, send you off to sleep if they're alpha agonists, etc., then they can work very well. But they come at a great cost. Dave Freeman's study from the States slightly has a heavy element of cost because they have to pay for these drugs from these studies, but showed that they're very poor rates of compliance and continuance and persistence with medication. And again, we know all of that. But what that means is that most patients, not all, hate their medications. And so MIGS don't necessarily just have to offer a lower target pressure more simply than other things that we use. They can simply offer a degree of drop freedom or drop independence, or even just drop reduction and getting away from some of these very intensive drop regimes that have been inflicted on patients to be worthwhile, or at least worthwhile to the patient, by which I mean worth the level of risk that we may potentially inflict upon them. So an eye stent may be an incredibly safe procedure that might not work, but when it does work, it comes at great benefit to the patient. There are large numbers of individuals, and we had a PPI group for one of the grant applications that we put in for looking at a version of MIGS. And the PPI group was phenomenally motivated to get away from medications, even a reduction from twice-a-day delivery to once-a-day delivery. A reduction from getting from 2 bottles to 1, from 3 medications to 2. Was a strong motivator for these individuals, not just because of side effects, but because of convenience, because of the impact on their life, because of having to remember to do all of those things that I think we sometimes somehow trivialize, because historically there's always been an alternative to incisional surgery, so clearly they're safer. That actually when you compare them to a 5-minute procedure at the end of cataract surgery with close to 0 additional risk, those patients would always, when we asked them, and asked them directly, they would prefer that to continuation with medications. Even if they ended up on 1 drop a day, they'd prefer that to having 3 bottles. There is some evidence. There are big, scary-looking metal devices that you can stick in that for the limited number of devices, so the limited number of RCTs available, show some preference for, show some benefit for those devices. Whether that's favouring eye stent at the time of cataract surgery, eye stent as a sole procedure, whether it's eye stent at the time of cataract surgery that favours the device, that means that there's, on the forest plots to the left-hand side, that there was a greater intraocular pressure reduction. These again using IOP as a surrogate marker rather than drop independence. that's favouring those use of those devices to get some pressure reduction for our patients. But these translate into patients that are happier because they've managed to dump some of their drops. There are other scarier, longer, metallic-looking devices to insert, which again sometimes work, starting to present the sort of results that the patients are interested in seeing. Medication-free patients at the end of 2 years. Some of the problem with this is that the rates of numbers of follow-ups reduce as they go through the 2 years of follow-up, and those actually aren't presented in this paper, so it's harder to truly assess the impact of this, and there's some loss to follow-up. But this isn't a specific critique of those devices or of that study, but the purpose of that is that, showing that, is that we know patients care about some of these end results. We can achieve some of these end results with these devices, and so surely we should be doing so. Because the question we're asking is, are these treatment effects worth it? The cost, the risks, the time to recovery. And the balance is clearly going to vary between the two different devices. Lower pressures at greater risk, greater percentage drop reduction or drop freedom, drop independence at the end of it, but at greater risk. That's always going to be an individualized question. That's going to be an individualized question for our specific patient in front of us, for their level of severity, for their target pressure, for the intensity of drop usage that they have at the moment, for the chances of them requiring further, more dangerous, potentially risky incisional surgery later if this fails. There's the whole gamut of patient severity and intensity of existing intensity of treatment will influence our decision making. But clearly, I think and I believe that we have to be able to offer these to those patient groups, because that's what they're asking for, and that's what they want. So, in summary, I think MIGS are going to form a crucial part of our wider spectrum of intervention, because it's actually what patients want. It's what patients are asking for. I think there then comes a secondary question. Can we afford it? Can the healthcare system afford the luxury of drop independence and drop freedom that comes at a significant cost, both the cost of the device, the cost of the follow-up, and all of those other things? That's a separate question for us. I think there is a risk that MIGS may not get into the mainstream of funding when we start to look at rationing and we have to look at what those healthcare pounds could otherwise be paying for. And it may be, and I fear this is the case, but I hope it won't be, that MIGS becomes the multifocal lens of glaucoma surgery. Most people and most multifocal lenses, so most people don't have access to multifocal lenses in the NHS. And some would argue, why should they? Maybe we should spend that money on diabetes and hips. I think the same argument may be applied to some of the minimally invasive glaucoma surgeries. The moderately invasive glaucoma surgeries that hit lower targets and lower pressures, that have an alternative, that may be an alternative to trabeculectomy, may sit in a different position in that treatment hierarchy and the different position in the risk and cost-benefit analysis. So I'm preaching to a moderately converted audience already, so it's only downhill from there, and because John Salmon's going to be arguing the other case. Thank you for the opportunity to try and keep you voting for the time being.